all the faculty and residents and my colleagues. I'm Dr. Yudhishthir, Assistant Professor of Cardiology. I'm here to introduce my department before we start with the case. So cardiology is the first super specialty branch which started in MGH 2012 June, and 2019 we enrolled 4 students for DM cardiology. We have 4 consultants. Head of the department Dr. Vansh Sharma sir, Dr. Ramanand sir, Dr. Arpit and myself. Facilities and infrastructure, we have OPD, IPD, non-invasive as well as invasive cardiology. And routine OPD, the routine investigations, lipid clinic, pacemaker clinic, as well as heart failure clinic. We have 10 ECGs, 3 alters, 2 TMTs, 4 echos, and echos are like advanced echos with TE, tissue Doppler, as well as live 3D. Last 3-year data of our procedures, we do the maximum number of EPRF in Rajasthan. Along with that, a very good number of PTCAs and all kind of pacemakers, along with BMVs and EP studies. EP is electrophysiology and radiofrequency ablation, sir. It is arrhythmias, regarding the arrhythmias, how to diagnose and how to treat. And along with that, coronary angiography and coronary angioplasties. Along with that, permanent pacemaker, CRT is combined precision devices, and AICD is defibrillator, cardioverter defibrillator, implantable. BMB is balloon mitral valvulotomy, and EP is electrophysiology. So these are the numbers. We are increasing every year, OPD as well as IPD, and a number of echos. Invasive cardiology is 3 cath labs. We have all Philips, latest ones with stent boost, 3D reconstruction, simultaneous CT scan and roadmap facility. And we have a wide spectrum of work with including coronaries, valvular and structural, as well as endovascular and arrhythmia, including temporary as well as permanent pacemakers. So this is like we have 3D reconstruction, abdominal. We have done abdominal aortic aneurysm stenting, carotid angiogram and angioplasties, and renal angiogram and angioplasties as well. This is a diagram of balloon mitral valvulotomy. ASD and VSD device closures also we have done with CRT device. These are all images. This is the intravascular ultrasound that we mostly use after stenting or before stenting for better outcomes. So this is also advanced technique of PTCA. External flow reserve to see if the lesion is causing the problem or not. This is rotablation. This is like used for highly calcified coronary angioplasty, high risk and highly calcified. This is also one of the advanced techniques. Cardiac MRI also introduced recently, done by Dr. Sanyukta, Department of Radiology. We have 24 number of publications last 3 years, 6 workshops regarding pacemakers, CTOs, bifurcation lesions, and IVAs. These are the. So now I would like to invite Dr. Vansh Sharma.
Good morning, all dignitaries, respected consultants, and my dear colleagues. I am Dr. Vansh Sharma, DM Cardiology resident, under the guidance of Dr. Vansh Sharma sir from Department of Cardiology. I'll present my CCR on the topic novel treatment in a patient of hypertrophic cardiomyopathy having refractory arrhythmias. Patient profile, name Mr. X, 42-year-old male. He is a resident of Kota, Rajasthan. He is a shopkeeper by occupation, married. Known case of hypertrophic cardiomyopathy. He presented to us with chief complaints of recurrent palpitations since 14 days and AICD, that is automatic implantable cardioverter defibrillator delivered shocks since last 8 to 10 days. History of presenting illness. The patient was apparently well until 10 days prior to admission when he developed sudden onset episodes of palpitations. Initially, the episodes were sudden in onset and termination. They were regular in rhythm, lasting 5 to 10 minutes. They relieved spontaneously without any medications and started occurring every 2 to 3 days. The episodes gradually increased in frequency approximately 6 to 8 days prior to admission before coming to Mahatma Gandhi Hospital. These episodes became associated with multiple implant AICD shocks. Mild dizziness during episodes and fatigue following termination was continued to the patient. Despite initial treatment at our Kota hospital, he continued to have recurrent tachyarrhythmias and frequent AICD therapies.
So when he came to you, he already had a implanted pacemaker.
Yes, sir. It was done by us only in 2023, and I'll mention the details in past. He continued to experience the recurrent tachyarrhythmias with frequent AICD therapies, prompting referral to our center for advanced management. On the day before coming to our hospital, while having breakfast, he suddenly developed severe palpitations again, and over the next 2 to 3 hours, he received multiple painful AICD shocks. He is perceived as a sudden forceful blow to the chest associated with lightheadedness. There was no loss of consciousness following the shocks, and he presented to our department following these. As we talk of negative history, the palpitations were not associated with any fever. There was no history of any underlying diseases like thyroid illness. There was no history of any drug intake, medications and alcohol binge. No history of any exercise or he did that is strenuous exercise. No history of any syncope or post-palpitation diuresis. Past history. He first presented to our department in 2023. He was suffering from multiple episodes of recurrent palpitations back then also since 1 to 2 years from 2021. He had been undiagnosed since 2 years, and when he came to us, he just gave us a history of DC giving shock at a local hospital in Kota. We took clinical history and we did a 2D echo that led to a diagnosis of hypertrophic cardiomyopathy. Following this, we did a EP electrophysiological study at MGH in 2023, in which we found out a monomorphic VT was induced. In EP study, we induce different type of arrhythmias, whatever the cause is, and then we treat them. Given the profile of the patient that he was having ventricular arrhythmias that time in his EP study, we did a coronary angiography that revealed normal coronaries. The patient was hence advised AICD implantation as a secondary prevention for his underlying disease, and AICD was done on 17/6/2023 at Mahatma Gandhi Hospital by us only. Then following 2023, he was completely asymptomatic until 2025. He was managed with antiarrhythmic drugs, and when he got again in 2025, he got 2 AICD shocks. Whenever a patient gets AICD shocks, we do the device interrogation of the patient. We did the interrogation of the device that revealed underlying episodes of atrial flutter, which was managed with increasing the antiarrhythmic doses and adding anticoagulation. Patient was
the defibrillator device. It will fire whenever there is tachycardia, like if the heart rate goes above a certain level.
Sir,
whether it's ventricular origin, atrial origin, will the device detect that or no?
Sir, yes, the device detects the type of atrial arrhythmias and ventricular, but sometimes the arrhythmia falls into a mixed morphology. There are 2 type of AICD. In AICD, there are 2 type of functions. It features a morphology, like it sees what kind of morphology the arrhythmia is having and what kind of rate the arrhythmia is having. If the morphology is a mixture and the rate is specific above the set points, it delivers shock, irrespective it is a atrial tachyarrhythmia or a ventricular tachyarrhythmia. Yes. So that is why it's of our interest that the shock that was delivered was a appropriate shock. We say appropriate shock when it's delivered for a ventricular arrhythmia, because we don't the device is never put for a atrial tachyarrhythmia. It's only as a life-saving procedure for
And
ventricle.
when you do the device interrogation,
Yes.
you can make out it records the ECG before and after the shock
Yes,
also.
sir.
So you can make out that this was an atrial arrhythmia,
Or
inappropriate shock, or ventricular arrhythmia, appropriate shock. Yes?
yes, sir. So 99% of the times it can be made out that whether this is a atrial tachyarrhythmia or a ventricular during device interrogation. But this patient has that 1% in which we had to look out that what was, because he was having baseline atrial tachyarrhythmia also, as I mentioned earlier. In 2025 he has atrial flutter. So again he was getting shocks despite our antiarrhythmic therapy. Normally antiarrhythmic therapy suppresses atrial tachyarrhythmias. Yes, sir. Is this 42? Sorry, sir. Sir, genetic causes. Sir, genetic causes no, sir. Genetic causes genes mutations like myosin heavy chain mutation, myosin binding protein C mutation, and 65% of HCM are idiopathic. 65% are idiopathic, and rest 23% belongs to myosin mutations, protein mutations. Sir, this patient presented with palpitations and syncope. He just gave us history that he went to a local hospital and he was given a shock. There was no documents that what kind of rhythm was that he was given shock for. He was just given a shock, and then we continued evaluation.
The syncope was because of the tachyarrhythmia,
Yes.
not because of the outflow obstruction.
Sir,
Cardiac output fall
sir,
because of
both play a mixed role. LVOT obstruction, left ventricular outflow tract obstruction, and tachyarrhythmias both play a major role in syncope. It is said that in HCM, if a patient is having atrial tachyarrhythmias, it is not good. It is not a good prognostic sign. So in past also he was treated for atrial flutter. Patient was diagnosed with pulmonary COX on the basis of clinical and radiological evidence, just a part of his past history in January 2026, and he was started on ATT by a pulmonologist. Personal history: occasional alcoholic, reformed smoker, mixed diet. His sleep was adequate, bowel and bladder movements were normal. He has no significant family history of any sudden cardiac death, no significant family history of any early sibling dying due to a cardiac issue. Discussion: are these appropriate? As I discussed, are these appropriate AICD shocks, or these are just inappropriate AICD shocks? They are just being given for a atrial flutter or atrial tachyarrhythmia, or they are being given for an actual ventricular arrhythmia. A differential diagnosis based on our history of presenting illness. It can be due to an electrical storm, that is a ventricular tachycardia storm, due to recurrent sustained monomorphic VT. Reason I am saying is because when we did EP study back in 2023, a monomorphic VT was induced. That could one of the reasons because of these recurrent shocks. He is a known HCM with prior sustained MMVT, as I told. Palpitations followed by multiple AICD shocks, just recurrent ventricular arrhythmias, because atrial tachyarrhythmias mostly get AICD shocks very occasionally, not in such a frequent levels. Like he was having around 6 to 7 shocks. And inappropriate AICD shocks can also be a differential diagnosis due to baseline. He was having a history of atrial flutter, atrial fibrillation, and other supraventricular tachycardias, if any present. And third is AICD related causes. AICD related causes, when we keep two leads in RA and RV, the leads can dislodge, they can have a lead fracture. It can be due to noise, that the machine can detect it as a, whenever there is a lead fracture or a lead impedance issue, the lead can detect it as a noise to the machine and can deliver shocks. So it can be AICD related issue, although that would be knowing on interrogation. General physical examination: patient was conscious, alert. He was lying comfortably on the day of presentation. His BP was 130/17, right upper limb. Pulse rate was 82 beats per minute, regular and normal volume. All peripheral pulses were palpable. His saturation of pneumonia was 95%. Respiratory rate of 22 and temperature was afebrile. His CVS examination, all palpation, percussion, auscultation was within the normal limits. Rest other systemic examination were also found within normal limits. This was the baseline ECG that we took on the day of his presentation. The ECG depicts this is taken at a speed of 25 millisecond, and it's regular rhythm showing left axis deviation. There is no at a heart rate of around 70 beats per minute. There is the other only abnormality we could see is T wave inversions in high lateral leads, that is 1 and AVL. This was the ECG recorded of the patient when he was admitted for under evaluation for us, and he had palpitations. We recorded the ECG, and as we know, the baseline ECG showed normal axis and a normal rate. This ECG shows us a wide complex tachycardia with a heart rate of around 200 beats per minute. There is an axis change. Previous it was a left axis, and now it is a right axis deviation. And if we could see very briefly, there is a little AV dissociation also seen in lead 2. So these all features, AV dissociation, wide complex tachycardia, axis change, favor us a diagnosis of VT in this patient. This ECG was suggestive of monomorphic VT. We did the blood investigations first. All came within the normal limits. Creatinine was 1.1, magnesium we done, it was 1.8. All his troponins were done, that came negative. Imaging echo. This patient is a post AICD status, so we see the RV leads inside. We can see the RV leads. In this patient, if I could have a point, this is the interventricular septum, and if you could see there is asymmetrical septal hypertrophy as compared to the posterior wall. It indicates in HCM it is a diagnostic criteria having asymmetrical septal hypertrophy as compared to the posterior wall. Most common wall involved is interventricular septum, and also there was on Valsalva maneuver that there was increased in LVOT gradient. So these are HCM findings of echocardiographic findings in a patient of HCM. So we did the device interrogation after admission. Device details, it was a dual chamber AICD. Lead impedance, as I already discussed, sensing threshold and pacing threshold all were within normal limits. We went to the stored events inventory. The ATP delivered, ATP is anti-tachycardia pacing, delivered were 14 episodes. Appropriate shocks were 8, and there was no inappropriate shocks. All therapies were triggered by a sustained monomorphic VT. So we led to a diagnosis of ventricular tachycardia storm in this patient. These were the stored AICD electrograms. Why I had I discussed earlier that it can be inappropriate shock, because if I could show in the atrial lead, this baseline atrial flutter is going on to the patient at a rate of around 400 to 600. In the ventricular lead, the rate is about 200, but the therapy, the device was giving shocks to the patient. So we were earlier confused that whether these shocks were due to a very high atrial rate as seen as the A on the screen, and a little as ventricular arrhythmias, mostly the ventricular rate is higher than the atrial rate. But in this scenario, the atrial rate was higher than the ventricular rate because of background atrial flutter. But as we saw the different other electrograms, the device gave first shock as it is written attempt 2, and at that moment a ventricular rate, if you could see that it slowed down for some time in between. Here it slowed down for some time, but it again went back to the normal mode. After first shock, even the ventricular the rate didn't go down. It was the third shock that slowed the ventricular rate and reverted to the sinus rhythm. As it is seen, after the green line, the rate has been slowed, and the ventricular rate has been slowed down, but the atrial rate is still high. If you could see in the atrial EGM, it is still high, depicting that flutter is going on in the background. Sir, first it's set in the device. It starts with 11 joules. We can program it to 21, and the last is 41 joules. The first shock that is given at a lower energy. So and if it doesn't revert with that, then higher energies are being delivered by the device. Clinical diagnosis on the basis of clinical history, ECG we got monomorphic VT, and device interrogation also suggesting multiple episodes of ventricular tachyarrhythmias. We diagnosed patient as VT storm. VT storm is defined as 3 or more than 3 episodes of ventricular tachyarrhythmias in last 24 hours. He was fulfilling the criteria for VT storm. ACS, electrolyte abnormalities, Inappropriate AICD shocks, as I mentioned, lead impedance and sensing patients' threshold were normal, lead malfunction, drug or toxin-induced ventricular arrhythmias, all were excluded. This is the...
Why are you not calling them inappropriate shocks? Because this is firing because of the high atrial rate. Ventricular rate is never going up.
So, sir, because after the shock, the ventricular rate slowed down. It means
No,
that the arrhythmia that was caused...
The trigger for the shock is inappropriate. No, it's not supposed to deliver a shock as per atrial rate. That's what I understand. That's what you told us earlier.
Yes, yes.
It's supposed to deliver a shock when the ventricular rate goes up above a threshold.
Yes.
But that's not happening. There's no ventricular tachycardia happening.
Patient was having baseline atrial flutter, so initially we thought that these are inappropriate shock, but when we saw the ECG of ventricular tachycardia, it is completely showing off ventricular tachycardia. So this patient is having two arrhythmia ongoing. Ventricular rate was high. We have ECG also for that. So ECG was showing VT. So patient is having patient is having both arrhythmia. If you can.
Sir, इसमें this sir, actually this is an EGM. Sir, in this this is an EGM. EGM is in this device, in this thing we calculate the cycle length. So according to the cycle length, the rate is about 200 only in this. Yes, sir. The atrial rate is about 400 to 600 in this patient. Because in flutter the atria are just having a... Yes, sir. Yes, sir. Yes, and in this also it is saying that it is the device has recognized this arrhythmia as VT. It's mentioning right down it is VT. The cycle length. It is a cycle length, sir. We divide 60,000 with the cycle length to get a rate. So this is a cycle length, and no, sir, it because of noise in between the leads.
Calculates in terms of cycle length, sir. Because if we can see atrial cycle length is 190, 200 milliseconds. So atrial rate is around 300, and ventricular rate is cycle length is around 350. So if you divide 60,000 with 350, rates is around 170. Basically, two arrhythmia ongoing simultaneously.
So these are the ESC guidelines. Now, as we have diagnosed the patient as VT storm, these are the European Society of Cardiology 2024 guidelines for management of VT storm. The step 1 management as always includes the airway breathing circulation of maintaining the patient. We have to do sudden ICU admission. We have to get serial ECGs. As we have done serial ECGs, we got a monomorphic VT ECG. We have to immediately do the ICD interrogation as described in above, and we have to reprogram ICD and treat pain and anxiety. The step 2 is whether we have to see it is a hemodynamically stable or unstable VT. If the patient is hemodynamically unstable, then we have to give immediate DC cardioversion, synchronized DC cardioversion, and we have to revert back the patient to its normal rhythm. If the patient is having he is hemodynamically stable, then we manage him in under cardiac care unit with medical therapy. Step 3 is identify and treat reversible causes. As we have seen, there were no reversible causes. There was no history of any alcohol, any drugs, any strenuous exercise, fever that were precipitating the ventricular arrhythmia. Step 4 is antiarrhythmic therapy. As HCM is a structural heart disease, we first line drug is amiodarone only. Amiodarone we give as a bolus 150 mg over 10 minutes, and we start infusion over next 24 hours. It can be taken up to 72 hours depending on the type of ventricular arrhythmia. Next drug we use is lidocaine. It is preferred in ischemic VT or post-MI VT or also in refractory VTs. The dose is 1 to 1.5 mg per kg as IV bolus, and infusion we start at 1 to 4 mg per minute. Other advancing drugs, if the patient is not getting relieved from the storm, we can go to procainamide, mexiletine, and that is a class 1B antiarrhythmic drug, and others. As our patient was started on amiodarone infusion, he was also started on lidocaine infusion. He was added oral 1B drugs like mexiletine and propanolol, he was still having VT storm. So next step was for us to, we also, I would like to add that we also added deep sedation to the patient because to reduce the sympathetic surge. Sympathetic surge has a major role in precipitating ventricular arrhythmias. So we have to calm the patient and put him in deep sedation so that the sympathetic surge is not there. So we kept him on deep sedation, we managed him with antiarrhythmics, infusions, oral antiarrhythmic drugs. We treated all the underlying causes. We kept him on membrane stabilizers like calcium gluconate, and we also replaced magnesium sulfate. But still he was having VT storm. So we were left with the next option of sympathetic blockade as a next guideline based therapy. Sympathetic blockade I will discuss in the further slides, that what is cardiac sympathetic denervation, or how it plays a role in VT storm. We also had an option of as we are well equipped EP electrophysiology and radiofrequency center, we also had an option of doing radiofrequency. But when we did the electrophysiological study of this patient, he was having multiple foci of ventricular tachycardia, ventricular substrates. So there was no possibility of radiofrequency ablation in this patient. If there would be a single substrate, we would have done radiofrequency ablation, and that would have 100% treated the ventricular arrhythmia. So management, I have...
So one input for you and other residents, when you have a slide like this is known as a super busy slide.
Yes, sir.
It's impossible for people at the back to see the slide. Show the slide, just talk about the 11 steps in the management, and then use ChatGPT to make one slide for each of the steps. So one for step 1, one for step 2. फिर वो बड़ा बड़ा दिखेगा. It will be easier to speak also and easier to follow also.
Right. Management I have already discussed. He was planned for electrophysiological study. All the antiarrhythmic therapies were started, along with oral antiarrhythmic drugs, and anticoagulation was also added because he was having baseline atrial flutter. Despite optimal medical therapy, patient had episodes of sustained monomorphic VT. EP study revealed multiple foci, and then patient was planned for bilateral cervical sympathectomy as a life-saving procedure for his life-threatening ventricular arrhythmias. Because whenever a ventricular arrhythmia or a AICD is delivering shocks, a part of myocardium gets damaged. It leads to a decreased ejection fraction of the patient, and if it doesn't intervene at a right time, it can lead to permanent damage and even the death of the patient. So this time, sir, it was associated with dizziness only. Earlier when we were, yes, it was pre-syncope when we diagnosed it in 2023. Yes, sir. Yes, sir.
Equally same, isn't it?
Yes, sir. Yes, sir. Because he was, no, sir, it was present in 2023. He was having palpitations. He had a history of syncope. His ECG was showing changes, and that's why we did a next step was a 2D echo. It was suggestive of HCM, and then we did an EP study. And what kind of arrhythmia is predominating? Because we were having evidence of atrial flutter, but atrial flutter will not.
With clinical situation, no, VT storm is already there, you said.
Yes, sir.
But it's not showing in the clinical situation, is it?
Sir,
no syncope like that.
No, sir. He was having just dizziness because syncope was not happening because the timely delivering of shocks by the device. If there was no device, he might have syncope and even VF, then leading to death. So here device comes into play. It gives timely shocks to revert the rhythm.
If it's firing that frequently, then the battery drains much quicker also.
Yes,
right?
sir. Yes, you're right. The number of times an AICD delivers shocks, the amount of battery gets spent. Then it does not spend much battery on if it is not delivering any shocks. Sir, it depends upon the device. It varies from 10 to 14 years. If it is, and depending upon the, in such kind of cases, if the battery is, if he is getting recurrent shocks, the battery life may come to 5 to 6 years. If
AICD implanted, 2 days wet, and then 150 shocks maximum a device can deliver is 150 shock. and device depleted, and he came for device battery change to us from Meerut. Then we one day battery got depleted. Then we did RFA. Yes, sir. If device is delivering repeated shock, then we have to do something, because this was an RFA. No, this was not substrate for RFA, because multiple arrhythmias.
Yes, sir. He yes, yes. Yes, sir. He was on antiarrhythmic drugs and sir. No, sir. Basically, HCM is a very kind of disease, and yes, sir, progressive disease, and it varies with patient to patient. In this patient, he is having a high fibrotic burden. Whenever there is a high fibrotic burden, that arrhythmias tend to generate. We can just control with antiarrhythmics, but the fibrosis burden, the scar burden due to HCM depicts what kind of prognosis he have. Sir, it is a progressive disease. We can diagnose with a cardiac MRI, but as it is a progressive disease, we can then evaluate with yearly or 2 yearly follow-ups. That what kind of fibrosis is progressing, whether it is the disease is just not progressing or stayed at his time, but it is a progressive disease, sir. So that is why he has progressed from last 4 to 5 years to having a VT storm now. So as I discussed, last step for the management we left was with cardiac sympathetic denervation. What is CSD? Cardiac sympathetic denervation is a neuromodulation procedure in which we surgically interrupt the cardiac sympathetic nervous system by removing the lower half of the stellate ganglion and T2 to T4 thoracic ganglion, reducing sympathetic drive to the heart and suppressing refractory ventricular arrhythmias. As I have told that sympathetic surge has a major role in ventricular arrhythmias. Sympathetic surge has been studied, and it causes a lot of abnormalities with the rhythm and causes excitability that leads to increased ventricular arrhythmias. Current evidence supports CSD, that is cardiac sympathetic denervation, as a life-saving procedure for refractory ventricular arrhythmias that continue to experience AICD therapies with maximal pharmacological treatment. What are the autonomic bases in this that we need to talk? Sympathetic hyperactivation is a key drive. What it is doing? It is beta adrenergic stimulation, releasing CAMP, that is CAMP and protein kinase A signaling, increasing it. Intracellular calcium overload, that leads to delayed after depolarizations and triggered activity. The most common causes of ventricular arrhythmias or SVTs are these three only: triggered activity, enhanced atomicity, and re-entry. Re-entry is seen in SVTs mostly. Myocardial atomicity, dispersion of repolarization. All of these are being triggered by sympathetic hyperactivation only. How does sympathetic hyperactivation occur? The patient having painful shocks, he is having recurrent palpitations, he is knowing that he is having a genetic disease. He is also knowing, he has been counseled that this disease has a risk of sudden cardiac death. It already builds up a very high sympathetic surge. On the back of it, we are having, the patient is having painful shocks. So it boosts the sympathetic activity. So result, recurrent VT-VF shocks, and for this we took a surgery consult by Dr. Shirish Gupta sir and team, and details of the procedure, what was done, what is cervical sympathetic denervation, and what was done with the patient will be shared by the surgery team. And I'll like to call Dr. Digjyot from surgery department.
Thank you, Dr. Vansh. Good morning to all the dignitaries, faculty members, and my dear colleagues. I, Dr. Digjyot Dhiman, under the guidance of Dr. Shirish Gupta, am going to talk about the management of this patient for whom we performed cervical sympathectomy. Before we begin, I would like to summarize the case. The patient that was referred to us was a 43-year-old male patient who came to the cardiology department with chief complaints of recurrent palpitations since the past 14 days and AICD delivered shock since the past 8 to 10 days. He was also a known case of hypertrophic cardiomyopathy. He was diagnosed as a case of ventricular tachycardia storm. Since all the antiarrhythmic drugs were administered and still there was refractory shock and even after all the medications, the surgical cardiac sympathetic denervation was planned. Before we start discussing the surgical steps, it is important for us to know the cardiac sympathetic innervation. The nerve fibers originate from the hypothalamus, travel along as preganglionic fibers, and then they come to the sympathetic chain trunk and comes to us as superior cervical ganglion, middle cervical ganglion, and inferior cervical ganglion. Then they carry forward as postganglionic fibers and terminate at cardiac plexus. The inferior cervical ganglion is fused with the first thoracic ganglion and is also known as stellate ganglion. So here you can very clearly see that the stellate ganglion is fused with the first thoracic ganglion, and the major cervical cardiac branches arise from the lower 1/3 of the stellate ganglion. And so here cervical sympathectomy is bit of a misnomer, because what we actually remove is the thoracic sympathetic trunk chain. Now moving on to the various methods of cervical sympathectomy. First is surgical, which could be either open or video assisted. Second is chemical ablation sympathectomy, and third is radiofrequency ablation sympathectomy. The open sympathectomy method is a great method for visualization and is a permanent solution. Its precision is high and success rate goes up till 98%. But here the post-op stay and the post-op pain of the patient is a lot more as compared to the video-assisted thoracoscopic sympathectomy. As talking about chemical and radiofrequency ablations, these procedures are mostly blind because they are image guided. There is no direct vision of the sympathetic chain, and there is a high recurrence rate because of the nerve regeneration. Therefore, in the current scenario, video-assisted thoracoscopic cervical sympathectomy was deemed as the gold standard method for the procedure that we had to carry out, as it gives us excellent endoscopic visualization. It is a permanent solution for the patient, and the precision and success rate is very high. The success rate goes up till the 99%. After the patient was counseled and told about the entire surgery, the relevant pre-operative investigations were done. Informed consent was taken, explaining the entire detailed possible outcomes and the complications of the surgery, and the pre-anesthetic checkup was done. Talking about the possible outcomes, it could be either Horner syndrome. Horner syndrome can take place if we damage the upper 2/3 of the stellate ganglion, as the nerve fibers from there travel up to the oculomotor. It could lead to pneumothorax, hemothorax, gustatory sweating, recurrence of bradycardia. These were all the possible outcomes. The patient was informed and then taken for surgery. Moving on to the steps, the patient was kept in the semi-Fowler position under general anesthesia. Double lumen endotracheal intubation was done, so allowing us for single lung ventilation, which was required for a proper vision. Three thoracoscopic ports were made. One 10 mm port was made at the 5th intercostal space in the mid-clavicular line, and two working ports were made. One was made at the 2nd intercostal space in the intercostal the anterior axillary line, and the second working port was made at the 3rd intercostal space just lateral to the sternum. The posterior parietal pleura was incised using a diathermy hook along the sympathetic chain. The stellate ganglion, the lower 1/3 of the stellate ganglion was divided using a harmonic scalpel up till the level of T4. We preserved the azygous vein on the right side, and we preserved the subclavian artery on the left side. Hemostasis was achieved, ICD was placed, and ports were closed. The same procedure was carried out on the other side. Now this is a video that shows how we use the monopolar diathermy hook to incise the posterior parietal pleura.
Can you do both sides from the same port, or do you have to
So
make separate
there is
ports?
one very advanced technique that is called uniportal video-assisted thoracoscopic sympathectomy. So we did not have we were not tuned to the surgery so that we could perform that. So that is why we took this patient in a semi-Fowler position, that is supine, with 30% head extension and hands abducted both on the sides, and 6 ports were made, sir. 3 on one side and 3 on other side. The conventional method of doing VATS is lateral decubitus. We go from the anterior axillary line approach. There is a baseball diamond.
And if you do open surgery, it has to be done on both sides.
Sir, for open also, if the indication here, the cardiologist asked us to do bilateral, we did bilateral, and even if we do open, we have to go from both sides.
I recall doing this case, and as she has mentioned, a W1Q was put in for it. As a prior preparation, since the patient had ventricular stoma and had several firings in recent time, we had put the external defibrillation pads before induction of anesthesia. A central line was secured for rapid administration of drugs in case of any emergency, and an arterial line was there to monitor the consequences. All these were there. There were several firsts in this situation. Possibly a bilateral cervical sympathectomy was done for the first time under general anesthesia, and the video assisted thoracic surgery for this was also done for the first time. We used a double amine tube that allowed deflation of one lung and ventilation of the other lung at a time, so that permits easy access to the anatomy, and you can do it at choice. So at one time left lung was ventilated, another time right lung was ventilated, of course at the cost of some physiological trespass. The lung was ventilated, but it was not ventilated, other lung was not ventilated, but it was perfused. So there was some ventilation perfusion mismatch, which is inevitable cost that we manage, and everything went on smoothly. Before this, we had done 3-4 cases of ventricular tachycardia, intractable tachycardia induced cases where this treatment was given. All were done with Dr. Sirish and Dr. Dangai sir, and 2 were done with the open surgery, and before that we did chemical symplectomy, ultrasound guided procedure. So this was the first video assisted cervical sympathectomy bilateral done in this institution.
Here this video.
You switch the automatic defibrillator off when you do this.
That's why the external defibrillator should actually, because sorry, we have not advised for that, sir. Use because we did not use it, we just said outtake. We should have backup of this, because during any surgery, device is off.
Command अपने हाथ में. तो बीच में हो जाएगा. Yes.
So this video shows how we divided the lower 1/3 of stellate ganglion using a harmonic scalpel. This is the sympathetic chain.
I was just telling Dr. Sitaraman that for non-surgeons, it all looks the same. कौन सा ganglia और कौन सा node.
Yes, sir. Sir, that is the cranial side, and so basically here is the head of the patient. Here is their feet. This is entirely the behind the lung, and on the right side. Here this is right side, posterior to the lung. The lung is here deflated, as done by the anesthetist. This is the sympathetic chain. These are the ribs that we saw, over which we identified the sympathetic chain. We divided the stellate from just the lower 1/3, here which we did the first step that was shown by the harmonic scalpel. Then we divided dissected out the rest of the sympathetic chain up till T4, and here we'll divide it and take this sample and send it for HP. The nerves here encountered are just a nerve of Kunz, which is an anatomical variation. Other than that, on the left side, we see subclavian artery, which we have to carefully preserve. On the right side, we find azygous vein, again, which was preserved carefully. Now moving on, the samples were taken and sent for histopathological examination, and the biopsy here confirmed that the sample that was taken was of the sympathetic chain trunk from the right and left side both. The post-operative stay of the patient was completely uneventful. The patient was allowed liquid diet after 6 hours. Soft diet was allowed on post-operative day 1. Patient was allowed normal diet and intercostal drain was removed on POD 2. Stitches were removed, and this is the photo from the first follow-up day, that was on POD 15, and the patient had no other complaints.
So the gynecomastia is because of the antiarrhythmics? Yes?
They have not noticed, just now noticed here.
Now I would like to call upon Dr. Vansh to continue this case. Thank you.
Thank you for the follow-up. And I'll continue the case. Within the first 48 hours after the surgery, there were no further sustained ventricular tachycardias. There were no AICD shocks. Patient was hemodynamically stable. Patient was gradually tapered off the antiarrhythmic infusions and drugs to a dose we used to give earlier. Repeat AICD interrogation after 48 hours revealed no new episodes of ventricular arrhythmias and no ATB therapies or shocks. Patient was discharged on oral antiarrhythmic drugs like tamoxifen, Cotron and propranolol along with anticoagulation and single antiplatelet therapy, and his ATT was continued. A little glimpse to the theory. Hypertrophic HCM is the most common genetic disorder, cardiovascular disorder, and it's the most common cause of young deaths in our country. Incidence being 1 in 500 and annual mortality of 1 to 2%. Most common cause of death in young individuals is HCM only, and I have previously mentioned the mutations. Diagnostic criteria is based on echocardiography, inappropriate hypertrophy, and the most important point is that first degree relatives of HCM patients should be screened. More than a 13 mm thickness is diagnostic. As this disease runs in families, it has a genetic history. The first degree relatives should always be screened. So for just a little info, why does HCM causes ventricular tachycardia? Multiple mechanisms contribute to ventricular arrhythmogenesis. Basically, HCM provides a line mentioned in Braunwald's textbook about HCM, that HCM provides both an arrhythmogenic substrate, that is fibrosis, and an arrhythmogenic trigger, that is sympathetic activation. These two play a major role in the ventricular arrhythmias or any arrhythmia that is happening to the patient. This is the phenotypes of HCM. HOCM is, as sir was describing, HOCM is hypertrophic obstructive cardiomyopathy. When the thickness is so much that it is obstructing the outflow tract, we call it HOCM. There are other variants, like our patient was having non-obstructive HOCM, mid-ventricular obstruction, that is MVO, apical HCM, it is a rare cause, it is also known as Yamaguchi disease, and dilated phase HCM. As we have mentioned the therapies also, I would like to add that invasive therapies for HCM, when it is a progressed disease, surgical managements like septal myectomy, because the septum is the major part involved, so some part of the septum is being removed so that it doesn't causes outflow tract obstruction. Alcohol septal ablation is also being used, and device therapy as a primary and secondary prevention, that is AICDs. AICD indications, massive left ventricular primary prevention, massive LV hypertrophy, history of, very important, family history of sudden cardiac death became a primary prevention indication for AICD. Extensive fibrosis, as we have mentioned, that we have in-house cardiac MRI now, and we can advise patients of HCM for cardiac MRI to see the fibrotic burden, and it would help us diagnose, as sir has told, that more than 10% fibrosis is indicative of ICD, no matter a patient is having arrhythmia or not. And ejection fraction of less than 50%. It is an indication in HCM. Secondary prevention, as our patient was having a documented or a history of sustained VT, VF or previous cardiac arrest. Why did VT storm occur despite an AICD? We might have a confusion for that. If a patient was having AICD, why does he have a VT storm? And AICD does not prevent a VT storm. We have to add antiarrhythmics only. and we have to do medical and surgical parts for HCM. It does not, it is just prevents sudden cardiac death by terminating them. As this patient, if he didn't have a AICD back in 2023, he would have not survived till now. These are some articles about because CSD is a newer technique for VT storm. Earlier it was being used for many other causes like hyperhidrosis and all that, but now it is being used for VT storm. It has been studied in Japan also. In the papers have been published recently in 1 to 2 years. Key learning points: HCM remains one of the leading inherited causes of sudden cardiac death. AICD prevents sudden cardiac death but does not prevent recurrent ventricular arrhythmias. VT storm requires rapid identification and correction of reversible triggers. As this patient was having VT storm, I would like to add that it was a very multidisciplinary approach. All steps, he came from hospital and he was discharged, was taken between 8 to 10 days of IPD. Our team, the anesthesia team, the surgery team, all had a role in it, and the patient was discharged stably on oral medications. Long-term management requires optimization of heart failure if he is having that, AICD surveillance. Family screening is most important, and consideration of catheter ablation if VT occurs. In our center, we are doing many RFAs for monomorphic VTs that have a single focus, and patients have no recurrence of any ventricular arrhythmia, or even for many SVTs also. And 100% success rate is being noted at our department. Almost 100%, 99%. Take home messages.
100% नहीं बोलना चाहिए, never.
Take home messages: cervical sympathetic denervation is an effective autonomic neuromodulation therapy. Although recurrence remains possible because the rhythmogenic substrate persists, because it's an HCM, the rhythmogenic substrate, the fibrosis will persist. Thus, timely CSD improves short-term survival, quality of life, and provides bridge to definitive therapies. Long-term prognosis determined primarily by the underlying disease, the fibrotic burden, what kind of he is having, and long-term prognosis depends upon that. He is our follow-up patient. After 1 month follow-up, ICD interrogations, no sustained arrhythmia. He got no therapies. As you can see, the device on his neck he is having. We are doing the device interrogation, and we see in that screen. The patient remains asymptomatic, highlighting an excellent early clinical response to the intervention. Thank you.